And I'm Stacy Farr, yes. And so we want to make sure we take a moment and just give gratitude and thanks to all of our supporters and partners, including BioNexus KC, Health Forward Foundation, Frontiers Clinical and Translational Science Institute, and UMKC. So thank you. And then here we're showing, this is every year, we have these IQ forums, and here is where we're almost, I can't believe it, towards the end of the year. We're at our September on what does public health transformation look like. And then our next update will be November 13th, where we'll be giving project updates from the Healthcare Institute for Innovations in Quality. So stay tuned. We hope everyone can come and help hear what we've been up to and where we should go in the future. That will be great. And then I know we've also been compiling, and thanks to everyone on our groups who's given input on what next year's topics should look like. I know we're working on finalizing those, and we'll be getting that schedule out as well, probably at the next session.
And thanks to everyone online and in the room for chiming in on what you want to hear next year.
Yeah, it's looking like a great schedule, so I can't wait. And then, so that brings us to today, which is really talking about public health transformation, right? What does this look like of, our aspirations to grow quality public health that's really best for all, and beset with, its own shortcomings in infrastructure, data policies, and talent, sometimes deficits that we just need more funding to support, and an imbalance in the focus on revenue over value. And today we're going to hear from a lot of really, really great speakers that are going to talk about this topic, and we're so glad to have them. And I just, was thinking and looking, at the landscape a little bit before this session and thinking about some of the monumental buckets of categories of things that have been changing in public health. And data and technology modernization. I know that's been a big push with the CDC trying to get for more of the real-time data and use of the AI real world data, as opposed to kind of the other previous uploading things that had a slower delay. The movement with public health and health care, and the alignment and ways in which there's, how can we best intersect to grow and support whole people. Workforce transformation is huge. Financing is always an interesting challenge in public health. Community partners and trust, very important. And we also obviously can't, have a session on public health and not also talk about some of the administrative, shifts in the landscape related to a lot of the things that public health does as its core mission, including, equity, reproductive health, and climate change. So I clearly am not the expert in this, and that means that we are really excited today to hear from all of our speakers who will be giving us their perspectives on the topic and where we're at, where we can go in public health. So with that, I would love to turn it to, I guess I can read all their names, or list, you can see it. Yeah. Yeah. So yeah, our first speaker, we're lucky to have Spring Schmidt, who's the CEO and president of the Missouri Public Health Institute, who will be talking about public health technical assistance and advocacy perspective for the local, partnered, and focused. Then our second speaker will be a nonprofit perspective, where we'll be hearing from Ray Campbell, the president of Fair Health, on nonprofit insurance data repository and research perspective, data's role in the future of public health. Third, we're lucky to have Jaron Raven, the president and CEO of Swope Health, who will be talking about the federally qualified health center perspective, which is also very important. All of these are going to be great. And then our fourth speaker is Megan McGuire, who will have the nonprofit public health accreditation standards perspective on building infrastructure, sustaining momentum, national frameworks for our next generation public health. And then, as always, if anyone online has questions, anyone in the room, jot them down. But, if you have questions, drop them in the chat, and then we'll have some Q&A and discussion at the end and solve the public health, challenges of the world together. So with that, I will turn it to our first speaker, to Spring. The floor virtually is yours, and verbally.
Hi.
Hi. Oh, and I guess I should click stop share, or
Yeah, stop share.
let's see, escape. I gotta see where to see it. Okay, so you can share.
Okay, thank you. Oh, my video stopped loading for some reason, but I will just try to blur my background. And it checked this right before we got started. So
Another try, Schmidt.
I will take my video off for a second. We already tested this.
Yeah. There you are.
Okay, sorry.
Yeah, perfect.
Hi, everyone. My name is Spring Schmidt. I am the CEO for the Missouri Public Health Institute, and I am also a recovering LPHA administrator, which is a thing that I like to say a lot, but it helps to speak to my desire to support our governmental public health system, especially our local public health administrators. I think I froze.
Your video froze, but we can hear you just fine.
Okay.
You can, wanna put
Sorry
it,
about that.
you can, if you put it back the way it was fine. We feel like we're looking at you.
All right. So, I really appreciate sort of the conversation around this topic, especially because my experience with the public health system is very much focused not only as a public health institute, a community partner. I've been in academic public health, and I have been a governmental public health administrator in a particularly large county, and now I support a lot of LPHAs who work across the state of Missouri. And so, as I have gone through my career, I have had a lot of evolving thoughts around what the public health system is, in addition to a focus on transformation. And I apologize that my video is not working, but I'm going to focus my talk today around the governmental public health part of the system in particular. And there's a couple of reasons for that. One is that in many ways, it is the system that is the weakest part of the public health overall system. If we think about all of the interconnected work focused on clinical care or focused on other aspects of nonprofit and community-based organizations, and our governmental public health departments, both at local and state levels, especially here in the Midwest, have been persistently underfunded. They've been overextended. They've been understaffed. They've been underrepresented in policy discussions. They've had a significant amount of difficulties in holding down their own roles. So in some ways, there are weaknesses in the governmental public health system aspect of the work that we do. However, one of the other reasons that I love this work and the focus on governmental public health in particular is that in some other ways, they are also one of the strongest parts of the public health system, in that it is our governmental health departments who have the primary role and responsibility to deal directly with the public on many of the topics that we consider to be public health topics. Not necessarily clinical care, but often facilitating access to care or providing supplemental or ancillary services to clinical care. Especially in many of our rural environments, do they provide a significant amount of ancillary and supportive or even partial clinical care around some specific topics that are critical to the operation of the system. And they, in addition to that role that they play as governmental health departments, our governmental system also has enforcement and regulatory authority that functions for parts of the public health system that we don't often think about unless they go wrong. And that's been a feature in public health for a long time, in that people don't necessarily think about the regulatory enforcement functions of health departments unless they go to a restaurant that they find or that they got sick at, or that they find to be sanitary, or they go to a hotel. Or something happens to them and they're exposed to a communicable disease that they're more concerned about, or they need supplemental assistance for a wide variety of some of the services they have, especially for like young families. If you talk about maternal child health and programs like WIC, it is the governmental public health department that has the role and function to provide a lot of these very direct services that are very often hidden from the public. And that makes them a stronger partner in the broader public health system. So a lot of the advice and sort of examples and processes that I'll be talking about today for a few minutes will be focused on the government parts of the system. I thought a lot about this opportunity to talk to you all based on the transformation aspect for this discussion. I have had this as a strategic goal for myself. It's been a strategic objective of our organization to be focused on the transformation of the system. There are many ways in which we have talked about doing that. There's been some things that we have done and tried to lift relative to workforce development, increasing our partnerships with others, getting more involved in public policy and advocacy work on behalf of governmental public health that we all consider to be part of transformation. But as I look at the landscape for where we are now, I think that there are some additional opportunities for transformation of the public health system that we haven't covered, and are headed into a time when it's not only opportunistic to cover them, but maybe critically necessary. And one of those opportunities is to have a conversation with the public about what services we consider to be part of the public health package. There's a big difference between the topics that public health might get engaged in, or where a public health approach might help drive community engagement, foster partnership, coalition building. And I believe in all of that aspect of the work that we do. But there is a different conversation about the services that are provided by our public health system. And we are at a point, especially if we are facing an increasing landscape of continuing government cuts, where the conversation that we have with the public about the expected services and the value to the public of those services is becoming critically necessary. And that means pushing some of those services out into the public sphere and having conversations at a strong local, state, maybe even federal level if you can, about the services of governmental public health. I also think that that gets coupled with an appropriate understanding and assignment of roles and responsibilities within the public health system. Public health is a big tent topic, and we tend to think that that's one of its strengths, is that we think everything is part of the public health system, and all of the services in government, all of the functions in society, all of the things that we experience in health and healthcare and social services are all part of a broader public health system. But we,
Spring, can I just ask you, I'm so sorry. I hate to interrupt. I never do this, but for some of us who are much less aware of public health, could you just talk about what you mean by services? I
yeah.
need a little more concrete basis so that I can follow, because you're moving very fast, and I just don't want to get completely lost.
Absolutely. So, there are, and I can make a quick reference here in that there is a series of what we consider foundational public health services. They are also related to what we generally consider to be the 10 essential services of public health. Missouri has a model of foundational public health services that is developed specifically for what we consider to be the baseline of services that exist. So there are some foundational areas that are part of that. Hold on just a second. And those would be considered services related to environmental public health. That means that those are usually like inspections of childcare facilities, hotels, restaurants, other food service delivery or packaging or creation, like within any given jurisdiction. There's a governmental responsibility. Many of our local health or state health departments are responsible for water quality, sewer or wastewater testing. From an environmental standpoint, there are some who do air quality testing, noise quality, when we feel like it will impact the public's health. All of those are under environmental public health. Missouri has programs that get involved in a wide variety of things relative to regulating like the distribution and places of nuclear waste, environmental disasters, things along those lines are all part of environmental public health. Communicable disease control is probably the one that people think about the most when they think about public health services. So if someone is identified to have one of 147 different communicable diseases that are mandatory to be reported in the state of Missouri, a local and state health department is notified of that. And then based on what that communicable disease is, there's a protocol that's followed for following up with the person who's been identified, finding out if there's something that they can do to get treatment, to protect their family, to protect their workplace. Like, what is the way in which we can stop transmission of a communicable disease? This happens, COVID is an example at which, many people have recent memory of some of the work that takes place in that. But this also happens in cases of sexually transmitted infections, communicable diseases like tuberculosis, or a wide variety of other activities with that space. And every one of those diseases has a different clinical protocol to follow based on how dangerous the disease is, and what is necessary to intervene to protect a person who has been identified, as well as anyone who comes in contact with that person. That is a service that is done by local health departments. They may also do preventable communicable disease work, such as vaccinations and screenings, and depends on the different types of things that are available in each of those areas, and the resources available to those health departments for how much they're directly involved in vaccination and screening processes. So those are all part of the things that they do to help control the spread of communicable diseases. There's another subset of that is related to vector-borne diseases. So our health departments are often a participant in tracking diseases that are born from rodents, mosquitoes, ticks, like all of those other sort of fun vector opportunities that people can encounter that have the ability to transmit diseases from animals to humans. And so our public health departments track those as well, and do their best to intervene to protect the public from the transmission of those diseases. They are also engaged in chronic disease prevention, so they may be involved in screening services for a variety of chronic diseases, helping do a variety of community health education, helping get people access to resources for chronic disease prevention, talking about the things that you can do, participating in studies for the things that you can do to help control chronic disease in your community as well. That's a much more difficult aspect of this, and it's where some of them get more involved in clinical care. They are responsible for community linkage to medical behavior and community resources, so they are always a node for other access to care. Many health departments have like a significant amount of relationship and access to other social services within their jurisdictions. Some of them also provide a wide variety of social services based on some of the services of their local health departments. So there are health departments with social workers, there are health departments with community health workers. Some of them have invested directly in behavioral health resources or medical resources that they specifically provide as part of their community functions. Public health do injury prevention services. One of the most common areas for this in Missouri would be engaged around policy work relative to bike helmet safety. There are some programs in public health that we maybe have services around drowning safety programs, or around communicating and doing education for other injury prevention in the community, and maternal child health functions as well. So
Schmidt,
yes,
that was fantastic. And we realized we diverted you from your
it's
presentation.
okay.
So feel free to get back. We don't want to take away from the time you put into your presentation. Thank you for that explanation for us.
It is really helpful because I think, and I appreciate the opportunity to do that, and I'll try to keep this last part brief. It's really important that public health do a better job of communicating the narrative of what it is they do. And a big piece of the transformation that's necessary now is that public health has historically had the opinion that they were better off working in a kind of a hidden way, that they did their best work when they prevented something from happening, or from really receiving public attention, because they stopped something from happening and they moved on to the next thing, and they kept that part very quiet. Except that also means that they have not been able to build all the time really strong, cohesive narratives about the good work that they do in communities. One of the reasons that I talked about this title for my part of this presentation being focused on getting local and partnered and focused is because we have been finding an increasing amount of public engagement and even public trust the more local the services and the community engagement is. And that makes sense in some ways, but not in others, at least in terms of the way that we've been viewing the world in a post-COVID way, or in terms of the current political environment around public health, in that there is a lot of energy towards the idea of distrust or the idea of disengagement and anger, and that certainly exists. However, we did a poll earlier this year. We engaged a professional polling company for the state of Missouri that did a poll about trust in our local public health agencies. And we found that 60% of Missourians had a significant amount of trust in their local agency. It was 2 points higher than their state health department. It was 12 points higher than the CDC. It was the second highest local government function that was the most trusted in Missouri, behind firefighters, but we were never going to beat firefighters in terms of public trust. But they were more trusted by locals in our state than schools were. They were more trusted than local government as a whole. They were more trusted than local police functions. They were more trusted than other local government branches of government. And they were more trusted in rural Missouri, even than they were in some of our biggest cities. There's a lot that we still want to do with that in terms of increasing that public's trust. And one of the reasons that we have focused on transformation being localized is because that is the best opportunity to directly engage the public in a conversation about services, in a conversation about trust, in a conversation about being responsive to what's happening at the local level. And that's where there's a significant amount of opportunity to transform both the image and the services and the role and responsibility of your local health department. That also requires being well partnered. So getting local, getting partnered, getting over barriers in terms of partnering with each other, finding ways to fill gaps, finding ways to braid funding, braid resources, braid political and social capital in order to make collaborations and partnerships that are truly meaningful. And my last encouragement relative to the transformation of the public health system is to get really focused. Public health is a big tent topic, but sometimes that means that we can go off thinking that we need to do, hundreds of different things in all of our communities. And all of those things are necessary and valuable in our communities, but they are not always the right role for the health department to take on, especially not by themselves, and especially not if they don't also have resources and investment to be able to do so. And there are many times in which this system has stretched itself so thin that a lot of their offerings and services suffer for it, because we try to do everything or be everything to everyone. And there's some real value in being focused and clear with your community about what you can and cannot do relative to the services of the public health system. And I think our transformation opportunities, some of it is an opportunity because we can do it and we have the means to do it and we have the drive to do it. And some of it is going to be an opportunity that comes from chaos in terms of funding at the federal level or funding at the state level and other things that are happening in the governmental systems. And that is going to spur a different kind of transformation. And if we take this opportunity to have the right conversations at a local level and with our partners with a clear and present focus and narrative, I think our opportunities for transformation are completely different than if we are solely in reactive mode. So I know I'm a little bit over the amount of time that I had, but I appreciate the opportunity to talk through a couple of those pieces.
Schmidt, thank you so much. We appreciate those comments. And
Yeah,
we've all been taking notes.
Yeah, we have. So will you be able to be on at the end for questions?
Yes, of course.
Oh, great. Well, then we have the pleasure of having Ray Campbell take over, and he's the president of Fair Health. Ray, do you have your slides? Talk.
Yes, I do. Let me share my screen. Hang on one second.
Fabulous. Thanks so much.
Good afternoon, everybody. It's a pleasure to be joining you. I wish it could actually be in person, but virtual does make things an awful lot easier. I really enjoyed, let me go into presentation mode. There we go. I really enjoyed your comments, Spring. Those were wonderful. I have spent a good portion of my career in state government, largely in the healthcare side of things, and just all of your comments really resonated with me, and I agree wholeheartedly. My comments today, actually, although I'm here as the president of Fair Health, and I'll tell you a little bit about them, actually, my comments probably relate more to prior jobs that I've had more directly in public health. So Fair Health has the country's largest collection of healthcare claims data. It was created out of a settlement between New York State and the insurance industry to make sure that the database of price data that the insurance industry uses for a bunch of internal purposes is not owned by the industry, but is instead run by a nonprofit. And so Fair Health performs this kind of, inside baseball function in a lot of respects with the healthcare delivery system, providing data to both health plans and healthcare providers. And we're now starting to use that data to branch out into more public health uses of it. But frankly, my comments today relate more to my prior life. I was a lecturer at the Harvard Chan School of Public Health, where I taught a class called Health Data and Public Policy. Before that, I was the executive director of the Center for Health Information and Analysis, which is the primary health data entity in the state of Massachusetts, called CHIA. Has extensive authority to collect data from health plans and hospitals and doctors and nursing homes and really anybody in the healthcare delivery system, and uses that to create reports and analyses for the legislature and the governor. And then before that, I was the executive director of the Massachusetts Health Data Consortium, which was a private nonprofit funded and composed of all the health plans and all the hospital systems in Massachusetts who were collaborating on health data and health IT projects. So frankly, my comments today relate really more to, I think, that prior life than my current life at Fair Health, but that it gets into it a little bit. So let me jump in, and really this will be, my comments are going to be very high level, and I'll try to be brief. I'll try not to talk too fast. Sorry, a lawyer from Boston. It's kind of a danger there. But in terms of when I think about public health transformation, my angle on it relates to data. And when I think about that, it's just impossible to avoid the fact that we're now in an era of intense politicization of public health. And there's a lot of distrust and fragmentation. We're now seeing some states start to go their own way on vaccine policy, things like that. And it's a very bad place to be. And in addition to echoing everything that Spring said, I think we just have to, I think acknowledge that we're not in a good place when it comes to fragmentation, and that we need to rebuild, kind of the trust and the consensus and the cooperation, because it's very hard, although those sound like soft skill things, it's really hard to make progress with data and analytics if you don't have trust and cooperation. And in fact, it's often the soft skills, the people skills, the relationships, trust, things like that, that are the hardest parts to master when you're trying to do something innovative with data and analytics. And so where we are currently with public health, although I found your comment, Spring, very encouraging, the survey data, that's very encouraging. I wouldn't have thought that. And that's, whatever, just very encouraging, because I think maybe scanning the national headlines, what you tend to come away with is much more of a sense of distrust and things like that. So anyway, the takeaway I have is that we're really going to have to get past this era of polarization if we're going to make really meaningful progress with data and public health. And to talk a little bit more specifically about artificial intelligence, because I think that's kind of the topic of the day. There's a lot of interest in it, a lot of excitement. I won't try to list all the different ways that artificial intelligence might and undoubtedly will revolutionize public health. There's been a lot of coverage of that. There's a lot of speculation. I don't have any doubt that in the longer term, the impact of AI on public health will be transformational. There's just so many ways in which it can be a force multiplier and solve, frankly, some of the really difficult problems that Spring was talking about. But I also think that there's a certain amount of unrealistic expectations at this stage. And oops, forgive me for 1 second. I work in a high security computing environment, and my computer wants to restart to patch, and I have to keep paying attention to the lower right corner of my screen, or I will suddenly disappear from your screens. Anyway, so yeah, okay. Forgive me. I was just getting a text from my assistant about my computer restarting if I don't keep hitting snooze. Anyway, like I said, I think that over the longer term, the impact will be transformational. And in the shorter term, there's actually, I think, a bunch of low-hanging fruit. A lot of public health is about communication, and AI, generative AI, can do some really wonderful things in producing content that's geared to different communities, that's very clear. It can make it a lot faster and easier to generate content. So I think there's some things that'll be happening sooner rather than later. But if you look at other major technological revolutions, whether it's electricity, the advent of computers, personal computers, the internet, mobile technologies, none of them result in an instant transformation. Pretty much all of them have taken 10, even 20 years for the deep fundamental changes that they enable to take place. And it's less about the technology, and it's more about humans adapting the way they think about things, changing business models. All that takes time. And so as much as I expect AI to have a big impact on healthcare and a big impact on public health, I think some of the overblown predictions just aren't going to come true. And in fact, there's signs that AI is following the traditional hype cycle that I think it was Gartner first, published a piece that talked about when exciting new technologies come along, there's an initial, a period of intense excitement, and then when things fail to live up to that, there's what they call the trough of disillusionment, where kind of things come back down to earth. And then over time, you get the kind of longer term mature adoption and value proposition of the technology. So I think we're probably going to come a little bit off of the hype high that we've been having with AI. I think that there's a bunch of signs, frankly, that large language models, as amazing as they are, can't solve every problem. So anyway, I think AI, unbelievable. It's been a remarkable thing to witness. But I think expectations that it's going to, solve our problems in public health or in healthcare in the short term are unrealistic. And I would point out sort of the last bullet point on this slide, hostility to regulation. In addition to, I'm a big believer in government and the ability of government to make positive difference in our lives and in our communities, particularly in the areas of healthcare and public health. But even if you sort of believe in deregulation and limited government, there are cases in which less government leads to slower adoption of technologies. And that's what I wanted to talk about briefly, which is with the last major technological advance in healthcare was the shift from paper records to electronic health records, which didn't really happen all that long ago. As recently as 2010, adoption of electronic health records by hospitals was in the low double digits, like 15% of hospitals nationally had electronic health records. And for physician practices, it was more like 5%. And it wasn't that people didn't realize that they were a good thing. It's just that you could think of it as a market failure, a policy failure, whatever. All the costs of implementing an EHR would be borne by the hospitals and the doctors, but the benefits mostly flowed to patients, to health plans, to society at large. Provider organizations were optimized for using paper records, and there just wasn't an incentive for them to switch from paper to electronic. So you had low adoption rates, and you also had a highly fragmented market. There were more than 700 EHR vendors, and these systems essentially didn't talk to each other at all. So in 2009, the HITECH Act, which was part of the American Recovery and Reinvestment Act, the stimulus bill following the 2008 financial crisis, had a huge investment in the adoption of electronic health records, and it had three components. Carrots in the form of massive incentive payments. $25 billion in incentives were available for adopting certified electronic health records. Sticks in the form of warnings that CMS would eventually impose reimbursement penalties on Medicare and Medicaid payments to hospitals and doctors that didn't have electronic health records. And then lastly, really robust national standards so that the systems, if you bought one, you knew it was going to work, you knew it was going to, it would have all the essential functions, and that it would be largely interoperable. Now, that's actually a whole longer conversation for another day, but interoperability is complex. But as a result of this program, the US went from really one of the lowest adoption rates of EHRs in the world to the highest. And the level of interoperability among our systems is much better than in almost every other country in the world. So I think it's an example of where the government was able to come in and with a government program do something that without it, I think that it would be, we still wouldn't have as widespread adoption of electronic health records without the meaningful use program. So I think something comparable is going to be needed when it comes to AI, because hospitals won't get paid more just because they purchase AI systems. And at some point, these vendors are going to want to make money, and they're investing just massive amounts of capital in their AI systems. I don't see hospitals and doctors spending, they don't have a lot of money. There's a lot of financial pressure on the healthcare system. Those pressures are actually getting worse. They're not going to be able to get paid more, saying, "Hey, I've implemented AI, pay me more." So it's as with EHRs, they'll implement them to the extent that it saves them time and money, that there's some direct benefit for them. But I think without something to change the basic economics here, I'm not sure why hospitals and doctors would, or frankly, public health organizations would race out to deploy this technology, especially, again, you've got a very fragmented market now. And who's to say that you're picking the right one, that it's being used the right way? The meaningful use program with electronic health records gave a lot of certainty to people that were looking to adopt these systems. So it's an example of where instead of saying the government should just get out of the way, government program dramatically accelerated the adoption of EHRs. So since that's not likely to happen in the short term, my advice to people would be to focus on what I call the data fundamentals, because even if you had an amazing AI system right now, in all likelihood, your own internal data systems are probably not up to snuff to get maximum benefit. And so really focusing on getting your data and analytic capabilities up to speed is a very good use of your time if you're excited about AI, but don't want to necessarily invest a lot in that first step. And when I say data fundamentals, that's the people, processes, and technology platforms that let organizations work with data, which is collecting it, managing it, analyzing it, operationalizing it, and sharing it with others. So that's what I would focus on in the short term, because I think ultimately really making a lot of progress with data and analytics and AI in public health is going to require more trust, more cooperation, and probably more government funding and government activity. So with that, I will stop sharing my screen, and my computer did not reboot, so I'm feeling good about that.
Great.
And I'll wait around for questions at the end.
Thank you so much.
Yeah, thank you so much. And should you end up rebooting, please rejoin. So we really do want to ask you some questions.
Absolutely.
Jared, I'd like to turn the floor over to you to give us the perspective from the FQHCs and SWOP in particular. Thank you so much.
Thank you. Hi, everybody. Hope everybody's doing well. I'm going to jump in here. Let's see if we can clear my screen. All right. Everybody seeing that? Hopefully.
Yeah.
Yep.
Great. Okay, perfect. I'll jump in then. All right. Today, we're going to talk a little bit about what public health transformation could look like. And I really want to focus on three things: meeting patients where they are, meeting communities where they are, and asking more of providers. So you're going to hear me kind of pick on organizations like SWOP Health over the next 5 to 10 minutes, and possibly raising our responsibility to do more for patients, although I think we're doing quite a bit already. But I hope to get a robust conversation that gets you at least thinking about some of the things I'm going to share today. All right, SWOP Health. Many of you know we were founded in Kansas City in 1969. It's a very interesting time within the city. Certainly a lot of turmoil in 68 and 69. It was many of you likely know the race riot story of 68. And in 1969, we came to the east side of Kansas City. I want to point out that I don't think that was a mistake. I think we, at the time, the founder anticipated some changing in the environment, some changing in the public health infrastructure, which I'll get into here in a moment. When we talk about public health, I want to really focus on three things, at least the way that we view it in terms of how we might achieve full transformation. A, health prevention, health protection, health preparedness, public health-based approaches, and health promotion. Number two, social medicine. If you've not heard that term, I'll get into it here in a little bit, but it's an acceptance that illness cannot be prevented alone. That social medicine is the marriage of medicine and social sciences. And social medicine seeks to train policymakers, healthcare professionals, and practitioners and their communities to prioritize access to food, housing, and other essential needs. And then thirdly, the social determinants of health, which I'm sure all of you are very familiar with. Let's talk a little bit about social determinants of health, because this is pretty important. And this is what I view as social medicine in action. If you view social medicine as the tool in which to think through holistic healthcare, now you're talking about putting those things and deploying those things in certain arenas of someone's life, certain areas of someone's life. So first we should start with education, access, and quality. And you asked your question, how far are you from schools, from accredited teachers? Are the schools funded equitably? And do you have access to higher education? A couple of thoughts here. You might recall that at some point, many of you might know that in trades were offered pretty readily within high schools. Then they moved to the community college level. And in some instances, higher institutions, bachelor's level. And that move, we think, shifted the access away from individuals who were certainly from low-income backgrounds. As an example, healthcare and quality. Do you have access to hospitals or clinics that are near you? When you go there, is the clinical teams there? Do they value you? Do they respect you? Do you find a kinness to them? Can you relate to them? Can they relate to you? Are they making healthcare decisions based on what they don't know about you or what they might presume of you? And then thirdly, neighborhood and built environments. Obviously, your social connections. Is there housing, stable housing in your community? Is there lighting? Is there green space? Is there places to have positive connections? So your social connections is next. Your friends, family, and work relationships, are they healthy? And then last, your economic stability and your ability really to rise in your economic kind of level or tier within your community. I'll make a couple notes about education because I think it's very critical. You may or may not know these stats, but in 1968, Kansas City, there were two non-Black students in KCPS. By 1971, that number, it was 51%. 51% of KCPS was African American. By 1981, 72% of KCPS was African American. The reason this is important is because the zip codes in which were impacted by white flight today have some of the worst health outcomes in the metro area, because when that population left, so did all the resources that went with them. And so I want to point that out as we talk a little bit later. I'll drill into some of the zip codes we're talking about. All right, I want to talk a little about the community health model. The community health model is as you think about the deployment of both social medicine and social determinants of health. This is what the community health model is. And that is thinking about the whole person. Can we somehow dare to provide all the healthcare needs that our communities need, that our patients need, in one-stop shop? Very difficult, very daring, but certainly worth the effort, and the data demonstrates that. This model dates back to China in the 1920s, also in Canada in the 1920s. You'll see in 1940, South Africa coined a term, community-based primary care, thinking about housing, direct care, food and nutrition, economic stability. And then we finally see it arrive in the United States in 1965 in Mountain Bayou, Mississippi, and an organization called Mountain Bayou Health Center, now called Delta Health Center. I'm going to play, see if I can get this to work here. I'm going to play this video to show you a little bit about what this looks like, the Mountain Bayou example. You guys are probably not getting that on your end, are you?
Not yet.
No.
That's unfortunate. Okay, well, I apologize for that, guys. This was a video of the Mountain Bayou Health Center in the 1960s and how they created their own co-op land for the individuals there, as well as a whole farming ecosystem that grew their own food and really helped them with the challenge of food insecurity, but also to ensure that they had healthy foods. And it's a shame that it won't play. I'll send the link at another time. I apologize for that.
That's terrific. We'll watch for that. That's great.
Okay, here's what's going to get you talking, I hope. So this is the 2025 homicide tracker in Kansas City, 142 as of just a bit ago, September 2nd is listed here. I am bringing this up because I want you to take your phones, those of you who are can access them right now, and I want to talk about 3 zip codes: 64132, 64128, and 64130. We're just going to go through a little exercise, and I would invite you to place anything in the chat. Let me go back here.
64132.
Yep. We'll go back here. Oh, come on. There we go. 64132, 64128, and 64130. These are some of the most challenging areas in our community. I want you, anybody for that matter, to take those 3 zip codes and tell me if you can identify a bank, a grocery store, or an employer over 50 people, that employs over 50 people. Any of those zip codes, if you can share that with me. And I'll wait. I don't know if anybody's in the chat. Let me share this with you. If you're having trouble, that's because there's not a lot there. There's not a lot of childcare or banking institutions or grocery stores in this community. 64130 actually is the zip code that Swope Health is in, at least our central location. It is often referred to as the murder factory. I didn't make that up. That's been a term that it's been referred to as since the 80s. I will tell you that there is a grocery store here because Swope Health built the grocery store, the Sunfresh, here in the 1990s, which will lead to some of my other discussions. But I want to share with you that violence happens where poverty lives, and poverty lives where opportunity does not. Number one, generational poverty is not self-inflicted, it's systemic. Number two, substance abuse often happens where the environment itself is the abuser. Number three, food deserts don't just happen. So we're talking about, I talked a little bit about KCPS and the resources that went with them and the subsequent removal of most resources. And then subsequently the poor outcomes that come after that. All right, so what are we getting for our investment in our healthcare system? I don't have to share with this crowd, the US spends far less on other countries on social safety net and social services. Other developed countries on average spend $1.70 on social services for every $1 that the US spends. In contrast, the US spends only 56 cents on social services for every $1 that other developed countries spend. What we see in this slide, although it's maybe difficult to read here, is we are spending money on direct care more than anything. We are producing a sick system, an ill system, as opposed to a healthcare system. We are not moving dollars upstream. We are moving dollars towards providers to help patients contend with illness in communities in which will only make them more sick. I want to talk a little bit about Swope Health. These are the quality awards that we were able to receive this past year from HRSA, the Health Resources Service Administration. This is not to highlight Swope. It is not a commercial for Swope, but I do think there's reasons why we received these badges. And by the way, the most in the state of Missouri for any community mental health center. And that's because we employ a housing coordinator to connect patients who are unhoused. We have an employment coordinator to connect patients to workforce development programs and employment if needed, including at Swope Health. We have a dietitian on staff who's certified in diabetes management. We hire from the community specifically and intentionally. We use AI tools towards predictive analytics, particularly around patient management, scheduling, and disease prediction. And then also, we provide stable housing for special populations, including housing for the severe persistent mentally ill. I think this is why, because we have those staff, those FTEs, we're able to go upstream and help patients and hopefully ensure that they improve health outcomes. I also want to talk about the program that I linked here that we have with Habitat for Humanity. 2 years ago, we launched a program within our organization. And mind you, Swope Health is 80%, it's an 80% female, women-led organization, most of the leadership team and others. We formed a partnership with Habitat for Humanity to build home ownership within our organization. Swope Health pays all upfront costs for your first-time home buyer classes and courses. And we are hoping to get you towards building generational wealth through home ownership. There's a young lady, our first graduate, who is a medical assistant here at Swope Health, who lives in a home much bigger than mine, and she needs it because she also has 3 kids. But she is our first graduate, and we're particularly proud of her for being now a homeowner. And this is just an example of us attempting to use and deploy thinking about social medicine and outcome improvement by way of going upstream and ensuring that individuals have a built environment, stable housing, and other things that they need to be healthy. Not only our patients, this includes our associates. Lastly, some of you may have seen this. Several weeks ago, Swope Health kicked off a 12-acre campus at 60th and Swope Parkway. And if you don't know where that is leading into our beautiful assets within the city, such as Swope Park and Starlight, and all those assets there that many people come here to travel for. But getting there, moving from here to that space or any other space close by, there's not a whole lot in the area. We were able to put together 12 acres of land to build what you see here, which will be a senior behavioral health and aging services campus that includes 200 units of senior housing. It includes a healthcare workforce center. It includes a community center. It includes a compounding pharmacy, a geriatric outpatient clinic, and then 75 units of housing for the severe persistent mentally ill. I am only mentioning this to say that I believe the future of healthcare, at least in terms of ensuring that we're going upstream, that we're thinking with a social medicine lens, that we're deploying social determinants of health, is really on providers, and particularly nonprofit and community-based providers who know the communities best. We are going to have to ask more of our providers and more of larger institutions. I'll give you a quick example. What would it take United Healthcare to build a park in Kansas City? They're worth $320 billion. What would it take to make that ask? What about CVS, who's $94 billion is their market capitalization, to build a school, to build a park, to build green space, to build a small deli that provides nutritious foods? What about Eli Lilly, the pharmacy company, who's worth $715 billion? What would it take for them to partner with community-based providers to build things in which both their products and services can be used, but also ensure that the community is getting better and healthier? That is the way that we view and think about public health transformation, through the lens of social medicine, through the deployment of social determinants of health, asking more from our providers who know the communities best, and asking more from other institutions who should be doing more from some of the communities that they benefit from. I will stop there.
Thank you so much. Thank you.
Thank you.
Where in the building is that millionaire footwork?
Jaren, someone's asking when the campus is going to open.
Yeah, great question. We believe we'll be in 5 consecutive years of construction. And certainly with $130 million as a community-based organization, I have a lot of fundraising to do. But we did kick off the groundbreaking several weeks ago with $40 million in hand for the first phase. And we believe we'll continue to be successful in our capital campaign because I think it's a great project and something unique for Kansas City. But to answer your question, 2030, we believe will be the completion date.
Fantastic. Well, I sure hope you'll stick around because there's so many questions that I want to ask, and I'm sure others as well. But for the last presentation, Megan McClare, who's the Chief Program Officer of the Public Health Accreditation Board, is she here?
Megan, there.
Great. Thank you. Thank you so much.
Making sure my screen is sharing, and I have to say it's super hard to go last because every presentation gives me another set of ideas. I really want to thank everyone for the opportunity to engage in this space. We actively have these conversations about what it means to make public transformation real, and so I'm glad to collectivize with everyone here. And by way of introduction, my background and introduction to public health is I was a community organizer in Central Illinois. Born and raised in the South Side of Chicago, went to school at University of Illinois, and so was doing work around environmental justice and healthcare access. I've done work at the federal level, spent some time at CDC, ran chronic disease programming in the city of Boston, so me and Ron have that in common. And then spent some time doing statewide policy, civil rights action work in California, and was the chief deputy director of LA County Department of Public Health throughout COVID. But in my current capacity, I am the Chief Program Officer of FAB, which serves as the sole entity responsible for accrediting governmental health departments. And beyond that work, we really support health departments and public health partners with technical assistance, tools, frameworks that strengthen the infrastructure, enhance workforce development, and modernize data and drive public health transformation. And we convene through our public health and systems and services work, we actually convene state-based partners to have conversations about public health transformation. And these state system partners include state and local health departments, state and county health officials, academic partners, partner organizations, and local leaders. And Missouri is one of those, and we're really proud to partner with Missouri in that way. And we know that transformation means more than just making changes and tinkering around the edges. It's really about a fundamental shift in how systems are structured, function, and interact. It requires developing a common vision and mindset, making sure that your workforce and capacity are aligned with modern needs, and creating a culture of continuous quality improvement and innovation through meaningful partnerships and community-led efforts. And there are two public health frameworks that serve as like the bedrock or cornerstone of this work. And one is the Essential Public Health Services, and it basically provides the full scope of what communities should expect from their public health system. This was developed in the early 90s. We updated it in 2020 alongside the de Beaumont Foundation to reflect what has changed in the 30 years since its development, to really speak to the broader responsibilities and expectations of public health and the broad sectors that play a role, and really emphasizing the expanded partnerships there. And the goal is really to move from programs as silos to thinking through systems that can assess, engage, inform, and protect health more collectively. Additionally, the framework on the right is the Foundational Public Health Services. We are the steward of those foundational public health services. So in that way, we continue to update it. We convene partners around it. It's the anchor of the 21st century learning community. And that outlines the core area and capabilities of governmental public health. So that's hearkening what Spring was noting of that there are unique responsibilities that only public health can do by mandate or regulation. And also things that we're better suited or should be expected of our governmental health departments. And the goals of these frameworks is really to give public health a common language, one that actually can allow the broader health ecosystem to align with it. And at the center and foundation to each of these is equity. And at the heart of that is ensuring that the services that are being developed truly reach those that are most impacted by them. And so FAB accreditation and recognition is one of the ways that we advance foundational capabilities for governmental public health. And there are a set of national peer-vetted standards and measures. And through the accreditation process, departments have a framework for communicating what public health is, what it does. It provides a structure for assuring that the parts in the whole all represent a comprehensive set of public health services and programs that can be delivered. And the process and tools, which are rooted in continuous quality improvement, performance management, are designed to support health departments in identifying and implementing the changes that are needed. So in many state public health systems, accreditation is being used as the driving force for transformation. It requires regular community health assessments, health plan improvement planning, and investment to a culture of quality improvement. So through accreditation, the public health infrastructure, and what we hear from health departments, it's the way that folks are able to experience and operationalize long-term systemic changes in how they do their work. So what does that mean in the broader landscape? And I think this has been referenced, and I think we all are grappling with a lot of these challenges, but it's hard to kind of talk about the opportunities without noting the challenges. We're dealing with rising healthcare costs. Jaron already shown kind of the level of money that we're putting towards treating folks without kind of dealing with the prevention components. The changing climate is creating more extreme heat, wildfires, heat-related illnesses, and vector-borne diseases, which is putting new pressures on the healthcare system and public health. The politicization of science, which Ron has already noted, is really fostering and generating a level of mistrust and a lot of confusion about where do you go for reliable health information. And it's reverting directions back into the healthcare system for things that could be dealt on a prevention side. And we're already actively seeing a lack of availability of prevention services like vaccines today. The sweeping federal divestment in health, so the current cuts to public health and Medicaid, the looming reductions that we're going to see in Medicaid moving forward is going to create major threats to the safety nets and the services that are provided to our most vulnerable populations. And we're still dealing with a workforce strain where we're dealing with attrition and shortages exacerbated by a pandemic response, and also by the lack of funding to be able to continue to fill those positions. And then also we have some good sampling of really strong partnerships, but they're often fragmented and they're short-lived because they're grant funded or too disease specific. So right now, this moment, and there's a high level of urgency, but we're being signaled to see that we have to do more with less. And I think the opportunity that sits here is not really about working harder in silos. It's really about how do we align our systems to collectively address the challenges ahead. And so what we see is a really tall order, I think can be addressed through a few different major areas. I think one, with aligning strategies. We know that the silos of being the silent player, I think that was spring around public health, and not working more actively with other partners, it no longer work long-term. We have to be able to coordinate prevention, response, and quality. Cross-sector partnerships, bringing healthcare, public health, community-based organizations, back together makes for stronger impact. And we have evidence in how we've mobilized emergency response, chronic disease. I think there was a reference to reproductive justice and maternal health programming. Those rooted in community and cross-sector partnerships are shown to be powerful, not only in improving our impact, but also improving the quality overall. Leveraging our strengths, there's more than enough work for us to do. And so really, how do we leverage each sector in the health system's expertise to really create efficiencies, to maximize impact, and making sure we're being most effective in what we want to do? And then over the last several years, healthcare has really leaned into whole person and value-based care models. And public health serves as a bridge, helping to make sure that we're thinking about system uprooted solutions and not just treating the illnesses and the diseases that are in front of us. And so how do we tackle that order? I think we have very recent history on being able to do that. I mean, COVID was our ultimate stress test. It revealed the fragility and the potential of our systems. When fragmentation existed, it led to duplication, it delayed responses, it heightened inequities. Yet at the same time, we also saw rapid innovation, communities and cross-sector partners rallying around the same shared goals. Hospitals and health departments sharing real-time data on ICU capacity, ventilation supports, and COVID cases. The regionalization of PPE to combat shortages among the workforce. Pharmacies and CBOs working to expand vaccination reach. Public health, faith-based and community-based organizations partnering to build vaccine trust, making sure we're aligning things with trusted messengers, working actively to overcome language and cultural barriers. We embedded medical teams into activations around our most vulnerable populations, including homelessness responses. And then when we get to the social and community context and other areas of support that Jaron also noted, we launched food banks and housing programs to enable safe isolation and recovery, and continue to provide other opportunities to navigate other economic implications from the response. This, in my opinion, is the greatest quality improvement project that we've done in our history. And we learned that systems that are connected, they don't just add the capacity, they multiply the potential and the impact. And these are lessons, they're very recent lessons. We're still reeling from those, and they absolutely should be leveraged right now. So COVID's pretty robust. I hope we don't have another pandemic in our near future. But I really want to note that there are a few low-hanging fruits where alignment is within reach and is actually actively needed. A community health needs assessment. Accreditation requires them, the IRS requires them. And quite frankly, as these public health cuts are hitting governmental health departments, they're balancing what to do with the critical direct services and the infrastructure work that's needed. These are some of the first things that have to be cut. And so this presents an opportunity, one, to support a gap, but also to manage duplication. So when we can integrate and blend the clinical data with the public health data, surveillance data, and we combine the information around the social and community context, we provide a richer and shared picture. And California's done some really interesting work. They're actively implementing a population health assessment across the state to really figure out how they can target and better align efforts around understanding health issues and responses. Even in Napa County, they're actually leveraging the community health improvement process to not only identify solutions, but also to find ways to braid funding in a more meaningful way. Another avenue is data sharing, and I think Ron spoke really well about kind of the challenges of the fragmentation that exists. And there's been a lot of federal investments through the public health system, and I think there's been active healthcare work really around better connecting data. But this is a chance for us to build interoperable systems where they make sense. Actually, Boston has a very great set of systems of being able to build equity dashboards, the ability to do leveraging syndromic surveillance from health, from all the hospitals to be able to understand and trend and monitor health issues that are impacting them. And real-time data helps to enhance coordinated emergency response, allows us to understand what are the upstream factors and the social needs that are driving some of the health outcomes and inequities that we're seeing. And it actually helps to better enhance the care that's being done. And then last but not least, I'll just note service and resource sharing. And this is really where you come together as a jurisdiction, you come together as a cross-jurisdictional entity to really find ways to maximize and leverage your staff, your resources, your functions to be able to address a particular social challenge. So this is right now when there's increased demands, limited resources, a shifting funding landscape. This actually is a critical tool for managing those pieces. It helps to pool talent, infrastructure, and knowledge across systems. And it doesn't just save money, it actually makes us smarter about investments and creates longer-term stability. And lastly, it helps to guarantee when we talk about the foundational public health services and ensuring that a resident knows what they can get is guaranteed in their community. It actually is a very essential component for addressing that baseline issue and really driving transformation, modernization, and effective responses when there's clear skies, but also during public health emergencies and emerging threats. And I think a very great recent example is the establishment of the West Coast Health Alliance, where California, Oregon, and Washington are now combining forces to better define what their vaccine guidance is going to be able to pool resources and determining how we get vaccines out to the community. And I think these are continuing to be promising models across the country. So as I noted earlier, is the 21st century learning communities, and we have 21 states, not by coincidence, we would love to grow. But there are several entities that are working across the country that are grappling with this issue. What are the tools? What are the strategies for public health transformation? And I just want to take a moment to actually celebrate Missouri, and not to tell you all about what you're doing, but I really want to acknowledge your very intentional approach to the foundational public health services. You've taken that framework, that national framework, and you've revised it to put it into the context of what works for you all. Through FIG funding, which is Public Health Infrastructure Grant funding, you all have launched a lot of support for local public health agencies. I know Spring is one of the lead TA providers in some of that work. But one of those pieces is actually doing an assessment, a readiness assessment for accreditation. And not only does it serve as like a pipeline for getting people into the accreditation journey, but it also is providing a very aggregate picture of what your public health infrastructure looks like. And so you can identify where the strengths, where the gaps are. And there's been a lot of work around how you can do that to address policy reviews. I think further, there's been really exciting work that's happening around the Rural Community Health Initiative, where you're finding new models to integrate medical care and social services to divert unavoidable ER visits. I know that Mercy Virtual in St. Louis has actually been recognized as being a leader in telehealth and innovation, and really reshaped how we provide care and services. And so I think that there's a lot to celebrate in Missouri, and there's a lot to build on as you continue to explore this transformation conversation. And so just to end, I just think that this is really a critical moment to really think differently about how we approach health and our health systems. The cost of fragmentation is far too high, and the opportunities for alignment are way too great to ignore, and there's lives that are on the line. And so transformation means that identifying meaningful partnerships that drive impact, tailoring strategies for those that are most impacted by the health issues you're confronting, collaboration at the state and local level that balance and strengthen the whole system, and identifying and operationalizing woven frameworks that ensure that we can meet the needs for today and for tomorrow. And so I do love the African proverb that if you want to go fast, you go alone, but if you want to go far, you go together. And stronger health systems require that we come together to build stronger, healthier communities for all that we serve. So with that, I will pause, and I'm excited to get into the conversation portion.
Megan, thank you so much.
That was absolutely terrific. All of you were terrific. So thank you so very much. So I had a bunch of individual questions that I was going to, and people have to speak up, otherwise I'll just keep talking. So that I was going to address to each of you, but I thought of a different strategy, and we have here today a young woman who's going to launch her career in public health, or is considering it, getting trained in it, thinking about advanced training, really wants to make an impact in the world. And you all have slightly different perspectives, but here's a young lady who's started down this quest, and all of a sudden, you talk about environmental health. We have an EPA getting rid of all of the regulations for water and air safety, and pushing back to coal. We have a head of the Department of Health and Human Services who doesn't want vaccines, and there are measles outbreaks going on. In fact, we have an entire sort of, we've had a big, beautiful bill that is going to remove a lot of the food that's so important to, human health, as well as Medicaid funding. And we've entered an era where sort of truth in science is devalued. And so this is a very challenging time. And, you've intermittently talked about rebuilding public trust, about the challenges of doing your mission with all of these evolutions. So how would you counsel and inspire this young woman to continue on her path and pursue a career in public health? And I'd really like to just go down the list from Spring to Ray to Jared to Megan, if that would be okay.
I'm happy to do that. I think my first piece of advice is that the vast majority of public health delivery is local. And so, yeah, I'm concerned about the federal government, and that's not to say that they don't have an impact. They certainly do. But the majority of regulatory enforcement for food safety is done at the local level. It's done in states. Public health delivery is predominantly done by states. And there are states that are still doing innovative work. There is innovative, real, deeply engaged community work happening in every community all the time. It's everywhere. It's frustrating. It will occasionally break your heart, but it is the most meaningful thing that you can do. And there is very real, powerful things happening everywhere.
In Spring, do you feel like we have the opportunity to make an impact locally?
Unquestionably. I think our health departments do this. They work to meet national standards. They work to be directly engaged in our community. And that's not to say that they're perfect. Like, there isn't any one of them that doesn't have a list of all of the things they wish they could do better. But there is very real local work happening in every community. They are tackling opioid issues. They are working on housing issues. They are participating in partnerships relative to violence in areas. They are tackling direct behavioral health engagement. They are working on preventing, the nationwide massive outbreak of congenital syphilis cases that we're having, and they're having successes in
And
this
you
space.
you eloquently said that public health's understaffed, underfunded, underrepresented in policy. Do you have a sense that the pendulum will swing and that, will sort of start to embrace more of an investment in the public health, the environment, food, et cetera?
I do. We've seen this swing take place historically over the course of the history of public health multiple times. This is really almost the exact same like backlash swing that took place after the 1917-1918 flu pandemic. Like this happens. However, these are services that are popular with the community. They don't always remember that until they're gone. But people do
Exactly.
not like eating in unsanitary restaurants. They do not like not having access to clinical and public health services. They do not like thinking that their water or that their air or that their environment is poisoned. And if they have a disaster in their community, they expect their community services to show up. And so sometimes it does take some reminders, unfortunately, and we wish that we could prevent that, and I would do everything I could to do that, but the pendulum will swing.
All right. Well, thank you. I appreciate that. Ray, what are your thoughts? You specifically highlighted the need to be rebuilding trust. How do we do that?
No, I mean, I thought Spring's comments were absolutely fantastic. I would second all of them. Am I just computer just said there we go. I would second all of them. I would add, and I guess this echoes some of it. You can't give up hope. I think there really are some great things happening, and you never know when the tide will turn. So I think, and some of the most important work that gets done isn't, you don't know where the finish line is or when it'll get reached or who will get there, but it doesn't make the work any less important. I mean, you can't always be on third base and run home to a big celebration. Sometimes you have to grind it out getting to first. So I think that it's just never been more important. So I would definitely encourage you to go into a career in health and healthcare.
And, with the some of the, more, I mean, it's hard still to get open access to good data, but to the extent that we can, that we get better tools to sort of mind and understand it, how do we sort of communicate and process that so that some of the things people and communities can do to improve the health and longevity and the quality of life of their population can more effectively be identified and communicated?
Yeah, I mean, well, I think that interoperability on the healthcare side of things with kind of clinical data becoming, more interoperable, that'll go a long way. But it is unfortunate that public health systems tend to be incredibly siloed. They tend to have risen from a particular federal initiative. They're funded, kind of in a silo. They're run in a silo. Just the data elements aren't standardized. The naming conventions aren't. I mean, the data isn't meant to be shared. And there was some good work being done with public health modernization to start that. But I mean, it's like a 10-year exercise to get public health systems up to snuff for true interoperability. So it's happening. It would happen faster with funding. It's happening on the healthcare side, but it's a shame that we're taking the steps back that we have been taking.
Thank you. Jared, I was so impressed with what you said. And obviously, as a cardiologist, I think all of health is due to what I do. But in reality, you made it very, very clear that that's not the case. And I'm actually very interested, maybe as a side note, just how I'm so impressed with the vision of the new campus you're building, how you got it funded, how you got momentum to sort of get others to share that vision. But I'd also like to hear your perspective about the opportunity for a young woman launching a career in public health to make an impact and make the world a better place.
Sure. I mean, I'll start with the most important question first, which is the future healthcare leader that you're talking about. I think, the deconstruction of the public health infrastructure that's happening right now should breed more leaders, right? We need more of her. We need more folks in public health to ensure that the policies that we're seeing now can be reversed in the future. And so, if anything, she should be encouraged because this is certainly a moment of job security and certainly a moment where her talents are going to be needed. And again, I think there's, as Ray and Spring mentioned, I think there's more than enough opportunities on the local level. The saying all politics is local is true, but certainly all healthcare is local. There's a lot of impact that you can make in your own community. In terms of the project, I think healthcare sells itself, a vision for the community sells itself. I'm very fortunate to live in a very giving community of Kansas City. I think understanding the history of the east side of Kansas City and all the work that would need to take place to reverse some of the outcomes that we see based on poor policies at every level, by the way. Communicating that and being able to get folks behind that, stakeholders at the state, city, and national and federal level was frankly quite easy. And really it all it took was big picture thinking, some data that demonstrates the need, and a poignant argument about the lives that we think we can change with support.
Fabulous. Megan, you want to give any other additional
Me too.
advice?
Yeah, I echo everything everyone has said, and I'll just say a personal anecdote that I fell into public health. I was doing community organizing around environmental justice issues and healthcare access issues, and it completely changed my life. And I was worried that public health would be too narrow, and it's such a whole. There's so many opportunities, and fortunately and unfortunately, in this current landscape, you can pick a health issue, and it's being impacted right now. And I think to Jaren's point is that, all politics are local. The result of this backlash is the result of organizing. And I think we need that similar force on the other side. And so I think that there's rampant opportunity to be able to find the issue that you care about, find a way to plug in locally. And I think to the question that framed this around how do you build trust, it's really in relationships. And I think those relationships that you do now with the community organizations, learning what residents want, will only make you a stronger and more effective public health advocate down the line.
Fabulous. Well, like always, I dominate with my questions and interests, and I really want to open it up for others to ask the panel questions they have. What's your response to this?
Oh, just thank you so much for all the insight on that. It's all very helpful. It is a very challenging time to be learning about it. I mean, I can say that all of my professors are, it's hard to talk about in class from being, they don't want to get thrown under the bus for saying the wrong thing, but then they also can't say that what's going on is right. And so it's very interesting to learn about stuff, and they have this curriculum that they've used for years that's been approved, and then there's 4 articles you have to read, and 3 of them are on the NIH website that have been taken down, and you can't access even to learn about the things that we're talking about. And so it's really a scary time, but I appreciate your work.
Look, the pendulum swings, and if you're left standing, it's going to get a whole lot easier because there's going to be a real need for people like you.
Yeah, and I will say the ivory tower thing with universities, when I was volunteering, I was in grad school and I'd have all these national things. And I actually was organizing for Champaign County Healthcare Consumers was the organization. And we were the first, we were the mobilizing force for the first entity to take away a community benefit status from a hospital. And it was because they were not advertising enough charity care programs. They were putting body attachment for people not paying their bills. But I say all that to say that one action completely revolutionized the whole market around charity care and financial assistance. And so that is a small county in Illinois that had the ability to have a national impact. And I think that my frustration in school was really channeled in working in the community and bringing that to your classmates and bringing that to your group projects and bringing that to the papers that you write. And it continues to hone your perspective and put the muscle behind what you'll do next.
Fabulous. Bruce, others? Yeah.
Well, again, really appreciate everybody's talk. It's really good to hear in an environment where we have real problems with public health. I guess my question would be, has anybody in the public health sphere done a real, and I hate to use the word, but I can't think of a better one, a real autopsy of what happened during COVID that could have been handled differently, that might have mitigated some of the anti-public health sentiment that's come out of it? I haven't seen anything, and it seems like such a major period of public health visibility and action that didn't always go right. So I'm just curious if there's been learning from that. Are we better off for the next one from the standpoint of not just the public health response, a response that engages community in a more drastic.
There's 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 dozens, if not hundreds of them, all from different perspectives, I think from different people. Dr. Galea is the new dean for the Washington University School of Public Health. He actually did a couple of different, including some like essay perspectives from different people who are working in different parts of the national public health landscape or local landscape. I also think that there were some recommendations that came out of, so Missouri did a series of recommendations. The Missouri Foundation for Health conducted a study about some of the biggest gaps in the public health system relative to COVID-19. That study was done by George Washington University. MFH, I think, still has it on their website that's available that was very specific to Missouri. There are a couple of national, especially some coordinated efforts from I think the Beaumont Foundation did a really large scale study on gaps in the system. The Trust for America's Health did a really significant kind of detailed breakdown of gaps in the public health system. There are a number of those uh, available. I think those are some sources that I would use that are going to be more comprehensive.
Are they are they part and parcel of your, and I mean all of your, the vision for transformation?
Yes and no. So many of them are focused on like COVID specifically, and that's not the day-to-day aspects of the public health system. It highlights some of the weaknesses. So yes, but also no in terms of some of the things that they reference are not things that are the day-to-day activities of public health by and large. They were extraordinary things.
So, Spring, I just think, correct me if I'm wrong, I think you had a slightly different angle to your question, which is, not, why did we have problems with COVID, but in many ways, the speed with which we generated a vaccine that, they were able to really, respond in sort of record pace to a pandemic was very good. And yet the perception is that it was terrible. And and you're wondering like, why is it that the perception seems so different than?
If I put a finer point on, because I appreciate that response as well as the others, but I guess to be a little more provocative, arguably a lot of the response wasn't due to the response in terms of was it a good response to COVID or bad, it was the overreach. I think that the public felt
Right.
that there was an overreach on the part of public health that impacted them in ways that they didn't agree it warranted. So that, to put a finer, that to me is what I'm talking about in terms of what I saw at least as the erosion of trust. It wasn't like, oh, this is a terrible response to COVID in terms of mitigating COVID, of treating it, of managing, the response. I don't think, in my opinion, that's just my opinion, that wasn't the issue. The issue was one of a disconnect between what public health did and what the public wanted them to.
Well, and that shifted over time. I was the local health department administrator for St. Louis County during COVID. And so I'm sorry for some of that. But I the overreach was present in many ways. I don't know that we yet understand whether or not it was necessary. It was the predominant response at the time for all of the science and ethics of public health in terms of what the expectation was. It was the tool in the toolbox. I don't know that we have shifted enough to really understand a broader array of tools yet in terms of that, but also most of us knew that the accusations of overreach were inevitable. The core governmental function of public health for the control of communicable disease is always a balance of individual liberties versus protecting the public's health. And most of the time, no one sees that at a massive level. We do the same thing on a small scale if we've identified someone with tuberculosis and we need to quarantine 11 people that came in contact with a tuberculosis patient. Those 11 people get individual communication. They understand exactly what has happened, and we will legally restrict their movement. And so applying that at a massive level is always going to constrict individual liberties of people who don't have a disease. And there's not a lot of other tools in the toolbox available to potentially control a pandemic.
Great.
Yeah, in terms of the term overreach, I mean, not that there weren't mistakes made, certainly, but I mean, I do look at it, and I think you have to look at it in the context of a pandemic that killed more Americans than every single solitary war in our history combined, in a 4-year period. So it's not as if this was a frivolous exercise. So I think that kind of a strong public health response was warranted by the nature of the threat. And I think the fact that there were mistakes, well, I think in any war, there's the fog of battle, mistakes are made. You learn over time. I don't think that's any different with the pandemic. So I think the politicization of the response is what I would point to, not to the overreach.
Can I add something? I just find it interesting. I think it's a very interesting discussion, and part of it is because I don't know that culture, and I mean the American culture and sentiment, could really contest against any public health response that's effective. One of the first public health Supreme Court cases ever was about a pastor in Massachusetts who didn't want to take a vaccine. It's called Jacobson v. Massachusetts. It happened in 1904, 1905. So I just say that sentiment's been around for a very long time. And sometimes I wonder if it's uniquely American and whether or not, no matter how effective public health practitioners are, whether or not we can defeat that.
Well, I've been instructed that Kaufman, who graciously lets us be here, is very anxious to turn this room over. So we're going to have to call it. But I just can't thank you guys enough for really a fabulous presentation. I learned a lot. I really appreciate it. And thank you all for participating and coming.
Thank you.
Thank you, presenters. Thank you all for saying yes.